democracy dies in darkness,
Right, yeah.
right? And so I think that what this process did was shine a light on some structural deficiencies in our state, in the democratic process.
What's up, everybody? Welcome to the Democracy Unfiltered. Here's your host,
This is Rob Thompson.
and this is Isaac Cramer.
Yeah, and we're here. We just got back from our trip up to Santa Fe with the NMSU Honors College class, focused on democracy in the everyday, the Sun Seminar. And I went up there, we were with a class of 14 students at the legislative session. And we're going to share more about what we experienced and what we learned about what democracy looks like in the everyday life.
Yeah.
Isaac, like for you, I'd love to hear more about, what your experience was like. I know that we spent a lot of time in the medical malpractice bill that was introduced. What were some of your observations?
Yeah, so for me, the whole experience was just very eye-opening and a very cool experience. And like you were saying, with the medical malpractice, that was kind of one of the bills we were really focusing on. And we sat in on a couple of the committee meetings. It was the Senate Judicial Committee. The chair was Senator Cervantes, and we sat in on a couple of those meetings. And at least for me, that's the first time I'd ever sat in on like a committee meeting, and it was just very interesting to see all the different interests, all the different juxtaposition, the opinions getting voiced, and really the democracy at play, because not only were the senators there, but we had all their staff, we had all the different interests, the doctors, the trial lawyers on both sides, and it was just a really cool combination of different interests playing into democracy. What about you? What did you think?
Yeah, I think when I walked into that room, we saw that the medical malpractice bill was streaming live, and we knew that it had passed the House, I believe, and then it was going to this Judiciary Committee, like you mentioned, and there was, only a couple seats available. We had to kind of sneak in and sit down, and we saw doctors with their white coats. We saw trial lawyers, and the mood was very intense. Like, clearly everybody was very invested in the outcome of what was going on. Prior to this, I had also seen a lot of marketing, online and even in doctors' offices about medical malpractice, and doing seminars and events to kind of raise awareness of how this is affecting patient access. And I think, following the journey of this bill, going from something that just was like I think New Mexico put together and they sent out like 11, different constituents in New Mexico sent around like 11,000 emails to representatives, and then how it got, this bill was created by this nonpartisan lobbying group, and then how that got sent to an actual bill in action representing the interests of New Mexicans was really interesting. And then seeing the bill actually, then be almost like, refined over time. It was sort of like taken, these different perspectives were taken into account, while, the average citizen could argue that we should just change this, and you should make it as easy as possible to practice in Mexico, and make the caps as low as possible. We had to take into account all the different stakeholders that were a part, and so seeing that in action was really was really enlightening. And Isaac, I think we saw, after we were seeing the bill, we saw there were some amendments that were added.
Yeah.
Right. That was kind of interesting point.
Yeah, definitely the amendments was something that was very interesting to me, because it was mainly one of the Democratic senators, and it's a Democrat-run Senate, and so the chair of the Senate Judiciary Committee, Senator Cervantes, is also a Democrat. but it was one of the other Democrats. I'm not quite sure her name, but she was mostly the only senator introducing amendments, and she introduced like a lot of them.
Mm-hmm.
And what was very interesting was, although those amendments passed the Senate Judiciary Committee, a lot of people were very unhappy with those amendments, and ultimately, I think none of them passed the overall Senate. They all got voted down on when it went to the overall Senate, which was pretty interesting. So the thing to think about is like, what was the intention of those amendments? And I think it's just really interesting to think about the different intentions of that senator too, because I think was also a trial lawyer, right? Or something like that.
Yeah, she's also a trial lawyer.
Yeah, and so is Senator Cervantes, the chair of the Senate Judiciary Committee. So it really,
Exactly like
there was some personal bias probably going on,
Yeah.
but
I think
it was interesting to see the different people on that Senate Judiciary Committee that were very invested, and then other people that were really not necessarily invested. I think there was like maybe like half of the members of the committee, and this committee has like eight people on it.
Yeah.
Yeah, and about half of the people were like very, very committed to talking about the bill and giving amendments, like we said, but the other half were like pretty tuned out, I'd say. Especially, I think on both sides, like Senator Thompson on the Republican side barely said much at all, and there were one or two senators on the Democratic side that were just it just sort of felt like they were there. But the Senator Cervantes, and I think this had to do a little bit with his leadership style. Senator Cervantes really steered the conversation really in the direction he wanted it to go, and he really wanted to get the last word in basically every time for everything. And I think that's partly his leadership style, and I think it's also partly because he felt invested in the bill.
Yeah.
Yeah.
I think another way we saw democracy at work here, democracy into the details, was Senator Brantley represents Truth or Consequences, and she brought up how they have this hospital there. They don't have access to a medevac to send patients out, and so, for example, like during 4th of July, Elephant Butte has a lot of folks visiting, and there's sometimes a lot of like hospitalizations or firework accidents. And so, she was very invested in like her community's, how the hospital would be affected by this, because there was one of the amendments that was added, was about like in-state versus out-of-state hospitals. So it would have actually affected her constituents very significantly. And so, not only do we have, all these different perspectives represented from like the stakeholders, but also like, seeing just the everyday like situation and like the on the ground like realities of something like the 4th of July, at Elephant Butte Lake, and how that like translates to to law, or to like the everyday folks. So yeah, I think previously, if I would have seen the medical malpractice maybe bill like in the newspaper or on the news, I probably would have made like a pretty quick judgment about like what should be done, or like what should happen. But now I think being in that room and seeing and hearing the history of this situation, the patient compensation fund, and the complexity of it, and all the stakeholders involved, I'm definitely, I think, more like intellectually humble and taking a stance of like, well, like, what are all the perspectives going on? I think that's what democracy really does well, is that it allows all of these perspectives to be heard and to get to like the best outcome. And that's what like democracy in the everyday is sort of what I took away from the trip. So yeah, that's one other big highlight for me as well.
Yeah, I think for me, it was similar. I think going into that room, I knew about medical malpractice in New Mexico, and I knew it was like a really big issue, but maybe I didn't quite know the full weight of it, or the full picture, because I think as the week went on, at the end of the week, we realized that even though it maybe was a good idea and it's going to help, it's also not going to solve all the problems. You know, there's a much bigger picture going on here, and even though it might help, we can't just assume that this is going to be like some sort of scapegoat, you know. And so we decided to get further information about the medical malpractice and about healthcare in New Mexico in general. We decided to talk to somebody who was actually in the room that day. Her name was Dr. Jones Boquin, and she graciously decided to accept and talk with us, and her information was just incredibly helpful. And a little backstory on her: she currently is at residency at UNM Medical Center in Albuquerque, and at one point she was the chief medical officer for New Mexico. So she has a really good idea of healthcare in New Mexico. She's lived here a long time, but she's also lived out of state, so she's able to, you know, compare and contrast. So getting that outside perspective, or really inside perspective of the healthcare in New Mexico was just really eye-opening, and it really helped us to get a better idea of the full picture.
Yeah, and we'll turn to that interview now, and then we'll catch you on the other side. So to start off, would you mind just giving? I know obviously we met and got a little bit of your background, and
Right.
you mentioned you left New Mexico, but if you don't mind, could you briefly kind of introduce yourself for our guests on the podcast, and then we'll go from there.
Sure. So my name is Erin Boquin, and I graduated from the University of New Mexico Medical School in 1995, and from the Las Cruces Memorial Medical Center residency in its first class in 1998. And at that time, the residency was a joint project through UNM and Las Cruces, and it was one of two residencies that have been set up as rural training programs to help increase primary care providers in the rural areas. One was in Santa Fe and one was in Las Cruces. You spent your first year in Albuquerque to do an internship, and then you went on for 2 years in that community. And so I spent those 2 years in Las Cruces, and my first job was in Espanola, which is in northern New Mexico. Mm-hmm. And I worked with that population and up in Los Alamos for a combination of 15 years. And then at that point, I left the state for a variety of reasons. Partly I had breast cancer that had recurred, and I couldn't get the treatment I needed in this state, or wanted, I should say. And also it was getting more difficult for me to work in this state due to my various health issues and the environment in this state towards physicians, specifically primary care doctors.
Wow.
And so, of course, not by individuals. Everybody's great with their own doctor. It's just the organized medicine. Anyway, so that's it. And then during COVID, I was out in California. I got through my cancer treatment, and I got better. And then there was COVID, and my husband and I decided to come back to New Mexico because for all the reasons that we love New Mexico, during COVID, they were able to do some really nice population health work around public health and proactive treatment. And so I returned, and I now am at UNM on faculty in family and community medicine.
Phenomenal. Well, I wanted to say thank you for sharing that, your story and your experience. I'm glad we connected. As a cancer survivor myself who had to leave the state for treatment,
Yeah.
That's also why I'm so passionate about improving, patient access in New Mexico. So,
Right.
So I really appreciate you sharing that, and I relate very deeply personally. Yeah.
Yeah. Yeah. And I relate with my patients over it because
Yes.
oftentimes it requires interstate coordination for care.
Yes. Yes. We met at the legislative session. Was that like the first legislative session that you attended?
No.
Tell me more about how you're involved with the political system in New Mexico.
So
This thing- okay.
my husband and I came in 1989, and we've been involved in various types of various parts of the political system, locally and statewide and nationally, and mostly in environmental issues, and then later on in education and healthcare, and so I started doing the Doc of the Day program in the early 90s.
Okay.
At that time, it was managed by the New Mexico Medical Society, and because we have a citizen legislators, which is basically that they don't get paid. Many of them were self-employed. Some of them didn't have health insurance. So during those early years, we would, do like an annual and then fill their prescriptions. And I think at the very, very beginning, we could do lab work. And then things got more complicated with malpractice and with liability, basically. And so we couldn't sort of provide that service as more and more of us became employed. It was one thing if you're a private practice person and you can just take care of them as your patient, but the quality controls on physicians in the state is sort of overseen by the Board of Medicine, and dictated by the New Mexico Medical Practice Act. And so you have to have a patient-doctor relationship in order to provide health care to an individual. And so then it became more like urgent care, and even then, it was more complicated. And then now it's really first aid and education. And obviously during COVID, it was a really awesome service because the education portion of it was very much how to keep your germs to yourself. And they did a great job because historically everybody gets sort of a upper respiratory illness during the legislative session because everybody's indoors and they're all working long hours. And so if one person gets sick, everybody gets sick.
Right.
And so now it's back in the 90s there was an EMT that sort of ran the program and kept us all on track, and he's since passed away, and now there are a separate sort of set of EMTs that are there anytime the legislative session is in. And so they provide first aid, and they'll call me in case somebody might benefit from additional information and or triage. And it's pretty simple stuff. And I don't write prescriptions like we used to.
Right.
And they have a couple of little samples like some cold medicine and eye drops and things like that. But it's really triage. And so I was there as the doctor of the day, which I've done.
Oh, okay. That's what you had,
year.
the stethoscope? Yeah.
Yeah. So that was me. And, it keeps me from losing it by keeping it around my neck. I guess it used to be back in the olden days that you'd wear a white coat so that everybody knew you were the doctor of the day.
Yeah.
But I don't wear a white coat anymore, so I don't wear it anymore.
Fair enough.
When I'm doctor of the day. And so, but it's a historical position. And I think I get a thank you note from the governor every year.
Oh, nice.
Oh, very nice.
Yeah, and sometimes there's cool stuff. And so I was there on last Tuesday and this Tuesday
Okay.
in that position. And it's a volunteer thing. It's not part of my job with UNM. It's just something that I've always done. And sometimes there's really cool stuff happening, like there was yesterday.
Mm-hmm.
And sometimes there's nothing. And so it just depends.
Yeah.
But I'll usually spend the afternoon sitting in the gallery, just listening. It gives me insight into the state.
Yeah.
Yeah.
Yeah. On the medical, on the med-mal bill, and I know that you said you were watching it last night as well, so you have an interest in it. Like, could you help us, understand, like, what are some of the different interests at stake in the bill? Like, we have the public, right? Like patients.
Sure.
We have like trial lawyers, which some of the trial lawyers are also on committees, right? We have doctors, hospitals, insurance companies, and how do those dynamics play together in the process of like democracy and legislation itself?
And it's really amazing, right? It's
Yeah.
just, the way our country is set up is that whatever is not in the Constitution is, sort of supposed to be under the purview of the states.
Mm-hmm.
And so, but medicine and healthcare have evolved a lot in the last 60 years. My dad was a doctor in California and very involved in politics, and so I was aware in the 1970s when medical malpractice became a real big issue, as costs in healthcare went up, and as more corporations were involved, the malpractice lawsuits became higher and higher, and then insurance agencies became more and more necessary for doctors to continue practicing.
Right.
And so in the 1970s, each state sort of bandaged together their own kind of way of dealing with that within their own state constitution and with their own medical practice acts. In our state, we didn't really have an active medical practice act at that time. So in 1971, we got our medical practice act sort of up and running, and better sort of definitions for our medical board. We had a separate board of medicine, a separate board of nursing, and we had a separate board for doctors of osteopathy and medical doctors. And so there was, a couple of different kinds of boards. And so all of that was based on the Medical Practice Act of 1971. And it hadn't been touched because everybody was afraid that if they opened it up for, change or debate, then the house of cards would fall down.
Right.
Because we didn't have a Medical Practice Act before that malpractice sort of crisis in the 70s. We sort of were ahead of the game because we could leapfrog into an appropriate solution for that moment, which included caps on compensatory damages.
Right.
And at that time, there wasn't a cap on punitive damages, but punitive damages at that time was more generally accepted to be rare.
Yeah.
Now, healthcare, the economics of healthcare has gotten much more complicated.
Yes.
And a price isn't just a price. A price is fluid. I'm sure you heard about this all last night, but
right.
There's different costs. And so then the lawyers were like, well, but we need to keep the patient whole. And so they're thinking of a number that will make that patient whole. And they're going for that number, but it doesn't necessarily correlate with who paid for the services and what damages were done, if that makes sense.
Yeah.
And damages are oftentimes interpreted by the person who was damaged, right? And so, and then after a while, that became the definition for punitive damages. In other words, there's compensatory damages, which is sort of basically compensating the patient for the costs of the error. And then there was punitive damages, which then became sort of commensurate with suffering.
Yeah.
and suffering is part of you know healthcare, illness, and so and nobody wants to deny anybody else's suffering because it's theirs, and so so then it became like hard to define the terms. And so now here we are 50 years later dealing with the Medical Practice Act that was written in the 70s, and both the economics of healthcare, the business of healthcare, the science of healthcare, the licensure of healthcare, the administration of healthcare has all changed.
Yeah.
And so then in 2021, they opened the act and made some changes, and yes, in fact, it did create the House of Cards to fall.
Right.
And the way that it did that is that the House of Cards to begin with needed sort of to be rebuilt, or at least scaffolded. And so they dealt with one little piece of it, and to some degree, I think the trial lawyer thing it comes into play because most of the people that are trial lawyers now lived through as children that malpractice thing and have lived through the destabilization of our healthcare system, which is both, national and international because of technology and what's possible in the face of what is probable. And we haven't really defined some of the basics, like who's responsible for what, who's, all of that. And so when you have some countries that have agreed on a socialized system and that healthcare is a right, that's one thing, but that isn't what our country has done.
Yeah, we're not. We're in a capitalist society where insurance companies are reinvesting their profits back into the market. Yeah,
that's right. I mean, that's just the bottom line, and you can say you believe in that or not, but that's just how it is.
And that's the reality we have to work with. Yeah. Yeah,
that's right. But there's always been an understanding that public health is a general good.
Yes.
So it's not necessarily a right, but it provides a general good for the population.
Yeah.
So and then it helps everybody. So if everybody gets vaccinated, fewer people get sick, and that helps the individual at some level.
Yeah.
And of course, the perfect example of that is polio, but we also saw it happen in other things. And so. But, those vaccines are expensive. Not having the vaccines are expensive. The whole thing it requires a better communication system. And so, you have different countries coming up with different solutions for the change. And I remember as a kid hearing that basically everybody had access to healthcare. And knowing, in my head that wasn't true, because I lived in different countries. I lived in Los Angeles. I mean, we weren't all treated equally, and so, but just now is when we're realizing that that's the case, right? We're not treated equally because it's a capitalist system, and it's based on both the generation of capital and the accumulation of capital. So people make money on healthcare.
Yeah, exactly.
In a lot of different ways. And so in other countries, you might have like a basic set of healthcare that are rights that are sort of more of an expansion of public health. So in other words, you can get your baby delivered at the general hospital, or you can pay extra and have your baby delivered at a private hospital.
Yeah.
And that's very common in other countries. And so it's sort of like you go to a sushi restaurant and everybody gets the 6-piece meal, but you can upgrade to the 12-piece meal, but that'll cost you.
Yeah, makes sense.
And so, but we haven't really come to that agreement in this country because it just isn't how our healthcare system is set up. And so at some point, ultimately, that's going to require a decision, right? Because right now what we have is we have it's that the structure of healthcare and the delivery of healthcare is based on different kinds of businesses that provide that healthcare, that are funded through different mechanisms, either through insurance or Medicaid or Medicare, or some type of grant system through, public health. And so we have federally qualified community health centers that are really kind of that 6-piece sushi meal, right? Which is just the basics.
Yeah.
And it's subsidized by a combination of state and federal funding in order to provide sort of a safety net.
Yeah.
Yeah.
But that's not in the Constitution.
Mm-hmm.
Right, and so those federally qualified community health centers are, to some degree, at the whim of the political system.
Yeah.
And so for a state like New Mexico, where maybe up to 70% of the population is going to be either on Medicare or Medicaid, the fluctuations in payment of those two programs alone will make a huge difference in the healthcare system for the state, because it's just there was in California. I was growing up in California. There was enough insured people that a doctor could charge them more than the people that had Medicaid, and then if they had Medicare, it all kind of evened out.
Yeah.
And so the problem is that that's not. That doesn't necessarily produce equality or equity, and it's up to the individual doctor how they manage that. And so then they tried to manage that through the federal and state programs, Medicare and Medicaid, by saying you can't charge them different or more or whatever. And so there's all these rules that then it becomes rules within rules within rules, right?
Yeah.
And none of it has to do with the practice of medicine.
Yeah, or patient outcomes, or it's
No,
managing the
yeah.
business model of reimbursement.
That's right. And so in the 1950s, when Medicare was put into place, and through the 1960s, it was done based on what the cost of healthcare, with a couple procedures, were in the different states. And so, say you were going to get your gallbladder out in Texas, it would be a different price than if you were going to get your gallbladder out in New Mexico.
Yeah.
And so that was sort of normalized, and that's how Medicare prices are still sort of gauged. And so Medicare is reimbursed higher in California for the same procedure as it is here.
Yeah.
Yes, you get more money in California for a gallbladder than you do in New Mexico.
Yeah.
Yeah.
And but there's a bazillion more procedures now. And so if there's a new procedure since then the monitoring is sort of off. And so we still haven't figured out a way to value healthcare either.
Yeah.
Like, is a gallbladder more significant than a cataract surgery? And
Right.
who's gonna, if you buy this machine and you spend less surgical time, but you know what I mean? Can you still charge the same things?
Yeah.
And because it's a capitalistic system, the magic is in the margin. That's where you make the money. And so that all of those things are hard enough in a state that has a lot of resources, but when you get to a state that doesn't have a lot of resources, like New Mexico, then it becomes really problematic.
Yeah, and if they also have the unfriendly malpractice, then it's just you're
right. But they also have gross receipts tax, and
right.
I mean, there's all kinds of there's billing issues, there's gross receipts tax, malpractice problems, and so it all sort of collapses. And so what the malpractice thing did, by changing in 2021, it made the whole house fall down. And that's because it preferentially destroyed some specialties.
Oh, interesting.
Yeah, so there wasn't anybody, I don't know whether there is today, but anybody delivering babies in Las Vegas because the OBGYNs were more sued than other people.
Right, because it's a more at-risk procedure. Yeah.
It is a more at-risk procedure, and the arguments as you saw during the testimonies had a lot to do with dead babies.
Okay.
Yeah.
I see.
And that's where that comes from, because everybody has a story about a dead baby,
Yeah.
and it's terrible. And so, but it's also terrible, it's also terrible not to have access to any health care in a whole swath of geographic area.
Yeah, but both things could be true, and we could still work towards a better outcome without. Yeah.
That's right. That's right. But that requires, that's the other part of capitalism, is that it theoretically thrives on competition.
Mm-hmm.
Yeah.
And so back in the early days of New Mexico, you had to apply for a CT scanner. A community couldn't just buy a CT scanner if they wanted it. There couldn't be, so many resources concentrated in one town.
Mm-hmm.
Okay.
But that's not allowed anymore, because that sort of reeks of socialism.
Mm.
Do you see what I'm saying? Like, if you can afford a CT scanner, then you're supposed to be able to buy a CT scanner.
Yeah.
But that means that ultimately there's going to be a difference in resource allocation for the state.
Mm.
Yeah.
And so all of those things are sort of esoteric, interesting concepts until somebody in your family needs one, right? And so at this point, what happened for me as a physician is that the practice of medicine became more unfriendly
Mm-hmm.
because it was treated as a business, and because I'm not great at business. I understand economics, like the exchange of resources, but if it's going to be up to me to give a vaccine to a child, I'm just going to say, don't charge him.
Yeah.
You know what I mean? Like
Yeah,
that's
there's like a moral premise first.
right,
Yeah.
right. And so, but and that's fine if the vaccine is $3 and I'm only going to give away 5 of them. But when the vaccine becomes $100 and there's 100 people that can't afford a vaccine, then that becomes a bad business plan. That
Right.
becomes a hobby.
Sure.
Yeah.
Yeah.
Yeah. And
yeah.
so, no, it just doesn't work. And so, and then as the practice of medicine is driven more and more by employed physicians, then the employers are, interacting with the practice of medicine.
Mm-hmm.
And in other states, there's rules that have either in the Constitution or the Medical Practice Act that say you can't have the corporations can't practice medicine.
Mm.
There is it's against the law to have the corporate practice of medicine. But in the state of New Mexico, because we didn't really have that foundation, we don't have that explicitly laid out. And so when you have private equity, there becomes more gray area.
Mm-hmm.
Yeah.
And so then that intercepts with malpractice too, because then everybody's pointing their fingers at everybody because, and I noticed that they were talking a lot about the Loveless not having any doctors available. And so, and that sort of, you sit there and think to yourself, well, is that the doctor's problem that Loveless isn't hiring OBs? Do you know what I mean?
Yeah, like it could just be like a talent acquisition. Like there's a lot of reasons why. Yeah.
Yeah, if the cost of they're just looking, Loveless or whatever company is just looking at the widgets.
Yeah.
So they have 300 babies that are going to be born next year. If we have midwives, then it's going to cost less.
Yeah.
And we're going to take this risk on, and we're going to cover that with malpractice insurance.
Mm-hmm. Yeah. It's just a business decision. Like, we're going to use locums, or we're going to, there's other solutions besides full-time employees because
Exactly.
maybe I need health insurance or
That's right.
401k or blah blah blah. Yeah.
But everybody thinks it goes back to the doctor.
Mm-hmm.
And so then more mistakes happen because it's poor communication.
Yeah.
And so then I mean, I knock on every piece of wood in my house. Have never had a lawsuit, but the cost of me doing my job or having a business then increases because I can't find people to refer patients to. So as a primary care doctor, if specialists are moving out of the state because they're being priced out of the market,
Right.
then my job becomes more difficult.
Yeah, you need to refer somebody to a urologist, like they have BPH and they're stuck and they can't get the medication they need. Like, what do you do? Yeah, like it's...
That's right.
Yeah.
That's right. And so, you know, and that is particularly true in New Mexico for specialties like neurology, rheumatology, neurosurgery,
Right.
OBGYN now, and so and gastroenterology, a lot, everything.
Yeah.
And so and part of that is because patients, because they were self-referring, and so those people were overutilized by some people and underutilized by others. And so in any case, that all becomes an economic equation, right?
Yeah.
And so everybody ends up with sicker patients that stay, and they have to work harder for 10 cents on the dollar, and pretty soon it just doesn't work out.
Yeah.
Yeah.
And in my case, my economic equation when I left New Mexico had to do with me being the primary wage earner, and then having cancer.
Yeah.
Right. And so I had to not only be treated for that cancer, but I had to continue working.
Yeah. Both were probably...
And-
yeah. Did you need to keep the insurance as well, or was it... Yeah.
So the first time I had cancer, I lost my health insurance.
I don't know.
And so then, ever since then, I've been employed.
Yeah.
But then once you're employed, then if you get sick and you're not making money for them anymore, it's easier for them to get rid of you or to marginalize
Yeah.
you.
That's why we need paid family leave, but that's a separate...
Right.
Yeah.
Yeah, I mean, that's good for a baby.
Yeah, true.
If you have a
Yeah.
baby. But it's not necessary. And not only that, but doctors like to work.
Fair. Yeah.
Yeah, and so I could have gone on disability, right? But that wasn't what I wanted to do.
Sure.
And so at the time, my employer just said, it's time for you to look for another job. And so when I did look for another job, I found it in California.
Yeah.
Yeah.
And so, but then I got better and I came back. But by the time I came back, this whole crazy thing with the Medical Practice Act had happened. And so now, it's just very hard to practice medicine in this state.
Do you think that the malpractice, like it's going to go to the governor's desk, like she's clearly enthusiastic about malpractice, what is your take on the effectiveness of this bill? Do you think it'll improve the situation, and what else, like what are the other big ticket items that if you could wave a magic wand would help improve? I mean, we covered a lot of them, right? But in New Mexico specifically, I mean, I don't know if we're going to dismantle the medical, it's a big
Well,
project,
I mean, I think we have to resolve.
Yeah.
There's a couple of things we have to resolve, and you can hear it in the testimony.
Right.
I mean, we shouldn't have babies dying as the quality metric for safe delivering of babies.
Yeah.
Like, you should have other quality metrics, right? And so, like, earlier. And you shouldn't have people, talk about having doctors show up drunk and on cocaine and everything else, right? Like, there should be other ways of managing the quality of a physician and the standards of the licensure.
Yeah.
And so that means that we have to look at our board of medicine and our board of nursing
I see.
and all of the licenses in our state to decide who's practicing outside of their license and and what is the scope of each member of the team.
Yeah.
And so that is a big piece of it.
Okay.
we need to be able to rely on the mechanisms of the licensing so that the patients in our state can be confident that if a doctor is licensed, that there's a certain level of quality that's been attained.
Yeah.
And so there's that. And then I think the corporate practice of medicine is a big problem.
Yeah.
We have to see better boundaries, because it's one thing to have a conversation about whether, and this was just one of the conversation I had today, was for the treatment of diabetes, the recommendations are if you have a hemoglobin A1C above a certain number, let's say 6 or 7, then you should be getting a hemoglobin A1C every 3 months. And you're actually practicing bad medicine if you get it more than every 6 months.
Mm-hmm.
Yeah.
So the hospitals will measure a hemoglobin A1C being done every 6 months as a win. But a doctor wants it done every 3 months.
Yeah.
Does that make sense? But the hospital is going to measure it every 6 months because they don't want to get their scores low. And so, so people get confused about what is the minimum and what is the median and what is the noid. Like what is like not enough.
Yeah.
And so there has to be, like, the practice of medicine and the business of medicine has to be separate.
Yeah.
And that's not a political statement, although it has been interpreted as such.
Mm-hmm.
It's just a matter of fact.
Yeah, like the incentives are driving behavior, and
Yeah.
that's
Right.
Yeah.
And licenses should be dictating behavior. That's where the
I
patient
see.
safety comes in.
Yeah.
I'm good with whatever. Like I've tried to work. I had my own practice. I've worked for the government. I've worked for private industry. I've worked for nonprofits, and
Mm-hmm.
I can't say that any of them are different. It's all the same.
Mm-hmm.
But if you're accumulating wealth, whether it be in property and or other things, then somebody's getting the supply and demand curve is skewed
Mm-hmm.
Yeah.
because there's an accumulation on one side versus the other. And in capitalism, it's there to benefit the corporation. And so, but in individuals, like in England, then those individuals that accumulate wealth will get the 12-piece sushi.
Right.
Yeah.
You know what I mean? You upgrade.
Yeah.
And so that's just all of the, so malpractice is sort of the canary in the coal mine.
Mm-hmm.
Although at this point, it was more like the whole infrastructure of the coal mine fell.
Yeah, it became a crisis that they could no longer,
Right.
It became this like bigger issue, even
Yeah.
though, and in a way, like, do you think? I think it was Representative or Senator Duhigg who said, like, even though you disagree with her on the issue
Yeah.
of her rhetoric but like her statement at the end was that this won't solve New Mexico's problem of doctor
Right.
shortages, right? What is your stand? What do you think on that? Like, I mean, it sounds like you're what I'm hearing is there are still more systemic issues that need to be addressed.
That's right.
Yeah.
And so, so my feeling, so I guess the reason I don't disagree with her, so tell me again what she said.
That if she was going to support the bill without the with the amendment stripped,
Right.
but she was saying that she'd be surprised if this truly lowered premiums, if this truly improved patient access, if this truly solved the problem of doctors leaving the state.
Right. And so the thing that I believe is that the conversation around House Bill 99,
Yeah.
shed a light on some of the pain points in our state, In other words, there's a lack of decorum around the practice of medicine and the behaviors in lawmakers towards physicians, like to have to sit there for a half day and hear, statements about rape and dead babies and cocaine. It's crazy.
With no other like counterbalance sort of perspective. We need to respect our physicians as well. Like that's important.
Just each other, our neighbors.
Yeah, exactly.
And so,
regardless
and that was all, and that was all on TV.
Mm-hmm.
And so, to some degree, it's coming back to democracy.
Mm-hmm.
And now I'm trying to remember what Amy Goodman always says. The democracy dies in darkness.
Right.
Yeah.
Right. And so I think that what this process did was shine a light on some structural deficiencies in our state in the democratic process.
Yeah.
And you can't have a capitalist state and then not pay your legislators and not expect them to accumulate benefits in other ways.
Yeah.
There was a legislator named Manny Aragon who was interviewed on a golf course in Arizona, and the question was asked, and what do you say to your people? What do you say to your critics that say you're bought?
Yeah.
And he said, well, why else would I go into politics? And he might have been joking, but it's like, why do people? I mean, to some degree, because the state of New Mexico has sort of had that Patron history, there's this idea that somebody else is paying the bill.
Yeah.
And that's just not happening.
Yeah.
And it's not good for the underserved, and it does not promote equity. It promotes inequity.
Yeah.
And because then the supply and demand curve is somebody else's.
Mm-hmm.
It's based on the needs of another population, not ours.
Yeah.
So does that answer what the question? So that was a long answer of the question about whether health. Do I think that House Bill 99 is going to resolve the medical malpractice issue? No.
Mm-hmm.
Because we still haven't defined punitive damages, compensatory damages, what the normal scope of practice is for certain licensed clinicians, and what is a reasonable outcome. And then if House Bill 99 miraculously cured all the problems with malpractice, would that then cure all the problems with healthcare? No.
Yeah.
Yeah.
And so that goes back to, if you're building a house, you have to make sure that the foundation is strong, and then the wood has to be strong, and then and then you don't start like with the painting on the outside until it's all done.
Yeah, you have like the systemic in the foundation, right? And
that's right.
The weakest, you're only as strong as the weakest point as well, right? Yeah.
That's right. And so yeah, I mean, I think we have a long way to go, and I know, our governor was our Secretary of Health previously, and she was in the House of Representatives, and she's pretty savvy when it comes to like how complicated these things are.
Yeah.
And I have no doubt that after we sat and chatted on Tuesday, that many people yelled and screamed in small rooms.
Oh yes.
Yeah, that had nothing to do with this. I couldn't find anybody for hours. You know what I mean? Like I was in the EMT space, just seeing, just talking to people, but everybody else was gone, and so they were all working the system and the democratic process, which includes, committee consensus, and then what can you live with, and all of those things.
Yeah.
And I certainly think that Senator Duhigg was smart to say something
Yeah.
about that. But I also think, and she's my senator.
Mm-hmm.
And so I stared her down that whole committee meeting. And I know that she heard from her constituents
There you go.
about her behavior.
Democracy at work. Yeah.
Democracy, absolutely. So, and that's what I love about New Mexico.
Yeah.
And so that's the part that really is kind of the secret sauce and why people stay and why I came back.
Yeah. I mean, with its imperfections, right? I think that people can have influence. There are
That's right.
there are people who care.
Yeah.
We, as you mentioned, we do hope that we can have a more civil discourse, right?
Right.
But I think that the state does have a lot of resources that it can throw behind problems. It's just making sure that we're solving the right problems in the right order, and that there's like you said, that we're attacking like the systemic issue, right? And maybe
That's
this
right.
is like a step in the right direction.
That's right. That's right.
Phenomenal.
Phenomenal.
Thank you so much for your time. I mean, you've been very
totally.
generous with your time and vulnerable in sharing your story and giving us more
Yeah.
of like the history and the background. We both learned a lot, and
Yeah.
I'd love to stay in touch. And
Please do.
And see how we can help. Together advocate for change in New Mexico and for
Right.
New Mexicans. Yeah.
Yeah, and we can send you our podcast once we're finished.
Oh, I would love that. I would love that. And I was chief medical officer for a very short period of time for the state.
Oh, were you? Okay.
Yeah, you can Google me. If you Google Oakland and condom.
I would never know. You're I mean, it makes sense though, because you do have a very like comprehensive view of like a lot of doctors are, like looking at their narrow perspective of like their work, but you're looking at like the whole
Right.
the whole system and the
That's right.
the history of it. And so I think we got lucky. I saw someone with the stethoscope, and I was like, Isaac, we need to interview somebody, and you seem very friendly and outgoing, so it worked out.
There you go. Okay, well, then get back to me if you have any questions, and I'm looking forward to hearing the podcast.
Yeah, thank you so
you.
much.
Thank you.
Have a good
Bye-bye.
one. Bye.
Bye. Thanks to Dr. Jones-Bachwin for speaking with us, and we really learned a lot, I would say. She really, like we were saying at the beginning, she was able to give us a really rounded perspective on the whole issue. Yeah. What would you say?
Yeah, I mean, hearing the history, the context, the all the players involved, and also all the other, related complexities of the medical system in New Mexico, it just, again, it's humbling, it's encouraging that there's just so much to learn, and how the democratic process really has helped, I think the bill's now on the governor's desk. If by the time this isn't released, if she signed it yet, but this bill went from an idea and it went through all these different stages, and we can talk a little bit more before we wrap up here about like the processes that we saw at work and what we took away from those.
Yeah, I think the process is really interesting because we might have it in our mind that it's just this bill, and really we're just debating the facts about the bill, but it's really this process that helps shape really what happens in the bill, because first it was introduced in the House, passed the House, and went to the Senate, where it went to the Senate Judiciary Committee, where we watched it. It got amendments put on, like we were talking about, but I believe it had 3 amendments that actually ended up passing the Judiciary Committee.
That's right.
And then went to the full Senate, and they struck down all those amendments. And keep in mind, this is happening the very last week of the legislative session, which is already a short session, 30 days. So everybody's scrambling. The representatives who were sort of the sponsors of the bill from the House, when the amendments were getting introduced in the Judiciary Committee, they didn't even have time to read them. Like, these were amendments that they were going to read that night to really understand the whole gist of them. So the process really helps shape it, because this is a crammed, sort of smashed process.
Yeah, it's like a pressure cooker in a way.
Yeah. This really important issue is, it's not just about debating the facts, it's about putting it in this system. So it really goes to show how, democracy is very complex. It's very complex, and the specific system we have in New Mexico, at least right now, maybe it will change, but at least right now, it's a chaotic pressure cooker, basically, like you were saying. So I think that's really cool to keep in mind.
Yeah. I think one other thing I'd add from my side on the process is seeing how, that these amendments got added and then they were removed, but there was also even before it went to the Senate, Republicans and Democrats were meeting to negotiate and work out a deal so this bill could be passed. And there was a debate that happened on the floor between Senator Cervantes and Senator Brantley, but the amendments were stripped at a 25-17 vote, so it was pretty close. And then the bill was finally passed, I think, in the Senate in a large majority, something like 40-3. So, what goes on in those behind the closed doors, we don't know. Like, could those have been, could there have been politics about other bills that could have been affected? We don't know, but it is interesting to follow the process and also see how even things like, there's some bills that don't get brought up to the full Senate because there's not enough time, as Isaac mentioned, with the 30-day process, and then you have the 3-hour debate. So and they're going until 1 a.m. on the last day. So it's just you have to think about the stamina of these representatives and the energy that they're bringing. And it also just made me very grateful that we have, such great folks who are working extremely hard. I think I would never doubt like the work ethic and the stamina that goes into working, and serving New Mexicans.
Yeah, I agree. They're definitely putting in the work. It's a tough process. It's a grueling 30 days, and other years it's 60 days.
Yeah.
Gotcha.
Yeah, but that's pretty much it for us for today. We hope that you learned something, and really that you found something that was interesting about the medical malpractice and healthcare in New Mexico, and just the democratic process as a whole. We know we found it interesting, and I think it's really a good thing to learn about this, especially if you're a New Mexican, because this impacts you directly. So.
Yeah. Well, thank you, Isaac. And we will be doing a couple more episodes throughout the semester on democracy and our experience in the class. And so who knows what we'll be covering next.
That's right.
But we're your hosts.
Yeah.
At Democracy Unfiltered.
Democracy Unfiltered.
Thank you for tuning in.
Have a good one.